There are a lot of really exciting abstract research, science being presented at ASCO this weekend, and I'm going to be sharing every day about really important presentations in breast cancer, gynecologic cancer, survivorship, quality of life, risk reduction. And so every day there are different sessions that present research, and then there are also poster sessions throughout where that particular project is not an oral presentation, but the researchers can present it as a poster and highlight their work. So although we have pretty much the abstracts for all of the presentations and the posters, and then when we hear the presentations and see the posters, we get more nuance and more detail. But I want to talk about a few important posters that are being presented. So the first is a poster presentation that is a meta-analysis, meaning they put a lot of research papers together and analyze them, of ovarian suppression with gonadotropin releasing hormone agonists. So these are drugs like Lupron and Zoladex. And we use these drugs for ovarian function suppression to shut down ovarian function in hormone receptor positive premenopausal breast cancer. Now, we've talked before about how we use ovarian function suppression in premenopausal hormone receptor positive breast cancer. For early stage breast cancer, not everyone needs ovarian function suppression. We have three options for endocrine therapy for premenopausal hormone receptor positive breast cancer, stage 1 through stage 3. We have tamoxifen alone, we have tamoxifen with ovarian suppression, and we have an aromatase inhibitors with ovarian suppression. And how I explain these to patients is this, that all are effective, but we have increasing effectiveness, meaning more reduction in the risk of breast cancer recurrence with an aromatase inhibitor and ovarian function suppression compared to tamoxifen with ovarian function suppression compared to tamoxifen alone. So as you go up that from TAM to AI and OFS, as you go up that chain, you have slightly better reduction in the risk of recurrence. However, you also end up with increasing estrogen deprivation. So you have increased efficacy, but you also have increased side effects. And so as we think about that, we have to think, does everyone need an aromatase inhibitor with ovarian function suppression? And the answer truly is no. There have been a lot of studies really trying to understand who needs it, who doesn't need it, and there's more that continues to come out that I'm going to be sharing. But what we know is that generally younger patients, especially those under the age of 35, a diagnosis, those who needed chemotherapy, those who had a grade 3 tumor, and other kind of higher risk features are going to benefit more from the AI with ovarian function suppression. But someone that has a lymph node negative small tumor, low molecular results, either on MammaPrint or Oncotype, probably can be okay with tamoxifen alone. So these are really nuanced decisions, and it's not as simple. It's really a conversation with each patient. But for those who do need ovarian function suppression, one of the things that we really look at is how can we do it monthly or every 3 months? Monthly is, of course, more time consuming, more labor intensive for the patient. You have to come in monthly. If you are able to do your Lupron or Zoladex at home, that's still a monthly injection. It's uncomfortable, it can be painful, and it's time consuming. And so one option has emerged has been, can we give it every 3 months? But a big concern about can we give it every 3 months has been, well, what is going to be the impact on adequate ovarian suppression? So is the 3-month dose enough to, just got to notice that my flight is delayed, so we're going to keep talking here. So is the 3-month dose sufficient, meaning do we get escape or recovery or resumption of ovarian function? And there have been some studies saying, well, probably the 3-month dose is okay, but there is some concern that, again, we're going to get ovarian escape. So what they did in this particular poster that's being presented at ASCO is they took all of the studies, or most of the studies that have been available about the monthly versus the 3-month dose and combined them to do an analysis of them. So they had in this analysis 15 studies that comprise of 4,324 patients. So this is a pretty large data set. And in that over 4,300 patients, about 2,100, about 48% received a 3-month regimen of Zoladex or Lupron, and the other half would have received a monthly regimen. And what they found was that the incidence of ovarian escape, meaning that, hormone levels are now not in a postmenopausal range, was very low. It was about 10% in the group, which we can talk about that. But the point here is that that incidence did not differ between the 3-month and the 1-month schedule. Now, nowadays, we're actually using more ultra-sensitive assays for monitoring estradiol levels. And so when they used an ultrasensitive assay, they actually found higher incidence of ovarian escape of up to 31%. So this is significant, meaning 1 in 3 patients may not have had adequate ovarian function suppression. And that's, an important point. But notably, even with that higher incidence, there was no difference between the 1-month and the 3-month regimen. And when they looked at estradiol levels at 12 weeks, they were comparable across dosing strategies. And then what they try to do is look just at randomized controlled trials, because when you do a meta-analysis, you're going to pull in all the data that's there, and you might get observational studies or retrospective studies where they look back, and those are really not as robust as a randomized controlled trial. So when they limited their analyses to randomized controlled trials, they also found very similar and consistent findings. The other thing that's important is, okay, well, we have this potential increase in, ovarian escape. Again, no difference between the 2 regimens. And then they looked at progression-free survival. So time that someone is alive without developing disease progression, and progression-free survival was also similar between patients who got the 3-month dose and the 1-month dose. So what did they conclude? They found that a 3-month dosing regimen of a GnRH agonist like Lupron or Zoladex achieves comparable ovarian function suppression to 1-month dosing with similar survival outcomes. And then for safety profiles, they found that most common things were as expected: hot flashes, joint pain, headaches, and nausea, but also no difference between the 2 dosing schedules. So how do I think about this now, and how do I reconcile it? And one of the things is I think it's really important as an oncologist to, and for anyone in medicine, but especially in oncology, is that we are constantly changing. We are adapting to new data always. And I will be honest that I have been very hesitant about a 3-month dosing schedule because I am concerned that we're going to get ovarian escape. And if we get resumption of ovarian function suppression, so we get an estradiol level that's in the premenopausal range, or we get a period or someone's bleeding, what happens is if you're on an aromatase inhibitor, you have to be in menopause for the aromatase inhibitor to be effective. Because if you're not in menopause, the aromatase inhibitor will reduce estrogen levels in from the adrenal glands and the adipose tissue or fat tissue. And if the ovary is functioning, the brain will send a signal to the ovary thinking, wait a second, there's less estrogen in the body, and tell the ovary, make more estrogen. So my concern always is, well, if the ovaries start to work or recover on a 3-month dose, it will make the aromatase inhibitor less effective. I have much less concern using tamoxifen with a 3-month dosing schedule because you don't need to be in menopause to be on tamoxifen. But now we have this study, and that's, I think, a decent meta-analysis. Again, I'd love to see, we'll see the bigger presentation, and I would love to see this published as a manuscript where we can really dive more deeply into the data. But, I think this is something that I would feel maybe a little bit more comfortable going forward about doing a 3-month dosing for patients on aromatase inhibitors. I probably wouldn't start right away. I do think that I still would start with a monthly dosing for a bit and then we could transition. But I think the other part that this raises for me is, historically, we have not been monitoring estradiol levels when someone's on ovarian function suppression and we get them into menopause. So, meaning we check their hormone levels after 1 or 2 cycles of Lupron or Zoladex. We see that they are ovarian function is adequately suppressed, and we start them on an aromatase inhibitor. And we generally do not continue to follow the estradiol level unless we're worried that we're not adequately suppressing someone. And so, given this with the ultrasensitive assays, that they have a 31% incidence of ovarian escape, that makes me think, should I be monitoring the estradiol levels more regularly in my patients? And I do think that I probably will start doing that because we worry, again, one of the things I would have loved to see is what were the outcomes in progression-free survival, so time without disease progression, recurrence, in those patients that had ovarian escape. And I don't know if they've looked at that, so I'm going to keep an eye out for that. So more to come, but I think this is an important one. I think it will change how we think about administering these drugs, the frequency, monitoring estradiol. So let me know. This is a great topic. Let's have a conversation about ovarian function suppression in general. So let me know all your questions, and then I can do a follow-up on this, answering some of those questions, and hopefully maybe elaborating on some of the data that will come out at the meeting. All right, my flight is now boarding, and so I'm going to run, and I will talk to you soon from Chicago.